Good evening, everyone, and you're very welcome to MS Ireland's webinar to mark International Men's Day. We're delighted this evening to be joined by Dr. Brian Sweeney, who's a consultant neurologist at University Hospital Cork. Dr. Sweeney has been asked to speak on the topic of men and MS for this session. And if you have questions, you can pop them in the chat and we'll try and get to most of them by the end of the session. And just to let you know that the session is being recorded and will be available on MS Ireland's website after the talk is finished. So now I'll pass you over to Dr. Sweeney for his presentation. Thank you, Brian.
Cheers, Aidan. Thank you very much. And I'm just going to get going now. So thank you very much, Aidan and Aoife, for the invitation, and thanks to MS Ireland, and thanks to the participants this evening for logging in on a Friday evening. I guess I'm going to talk around the subject of multiple sclerosis with some particular references around the issues that men with multiple sclerosis may experience. Now, to some extent, these are also the same, or to a large extent, these are also the same symptoms and issues that women with MS experience. But there are some specific things that are perhaps important for men who have the illness. And I'm just going to go back over some reminders that it's an inflammatory illness, an autoimmune illness. You get episodes of neurological problems which are separated in time, so over time and also in space, that is within different parts of the nervous system, and that you get inflammation and demyelination, as we call it, and then injury to the nerves, and that then leads to the long-term problems of dysfunction of the nervous system. The usual onset is between age 20 and 40, and the mean age of onset is between 28 and 31. And the treatment is to control the immune system or modulate it. And of course, the future aspiration would be for what we call neuroregeneration, which would be to restore the nervous system. And of course, a huge amount of work is going on in that area. What happens in MS is that you get, this is an area called the ventricle, a cystic space deep within the brain, and it can show areas where the myelin is lost around it, and these are kind of areas of demyelination. And in this scan of the, or this slide of the spinal cord, you can see this is normal myelin here, these dark areas, and then these areas which are punched out showing the loss of myelin, and that shows the what we call demyelination, and that's why the term demyelination has sometimes been used as another word for MS or another term for MS. We know that when this happens, then that it has effects on a wide variety of functions within the body, ranging from areas like mood and cognition, to vision, to mobility, to bladder and bowel function, and they're the different symptoms depending on the site where the areas of inflammation develop. A very important aspect of MS, is the, which I'm just going to mention as we go through the talk, and which I have discussed before, is around measurement, and that is to measure the impact the illness is having on somebody, and then also if you're going to give some treatment to someone for either a symptom or for the long-term outcome, to be able to measure that effect over time. So there are a variety of scales that we use. One of them is called the Expanded Disability Status Scale of Kurtzky. Another is called the MS Functional Composite. There's a test called the BICAMS, which uses a thing called the symbol digit substitution test as part of it to test memory. And then we can look at MRI scans. So for example, here we have somebody who does not have MS, and then somebody who has MS maybe showing some of the effects of the MS on the overall structure of the brain, and how the brain might age more quickly than it would otherwise do if you didn't have the illness. And then the other area then is around what are called biomarkers. So these are the chemicals that we might be able to measure in terms of in the blood or in the spinal fluid that might help us to determine how severe or not the MS was, or what impact the MS was having, a kind of another measurement apart from MRI, if you like. An area that comes up a lot in discussion is around MS disease patterns, and people will say, what kind of MS do I have, or what type do I have, whether they reflect underlying differences in the causation or the origin of MS, or whether it's just a variation which varies from more mild problems to more severe problems, is debatable. But the classic descriptions are relapse remitted MS, which is where you get a flare-up followed by a period of remission, and then another flare-up over time. What's called secondary progressive MS, where people who've had relapses and remissions might then start going into getting more ongoing and more progressive problems, perhaps with relapses as well, but in the background, a general increase in disability over time. The third pattern is what's called primary progressive MS, where from the get-go, there's a slowly, steadily increasing situation where the symptoms are getting more severe gradually over time without a remission. And then lastly, an area where people can have what's called benign MS, where they seem to remain remarkably well. So having flare-ups occasionally, but remaining remarkably well in between and not seeming to accumulate any major disability over time. This is controversial as to whether this will evolve into having more problems in eventually after 20 or 30 years, but still remaining remarkably well over the short to medium term. Another idea that comes into the relapse, the kind of descriptions is relapsing. So somebody who has a one-off episode, who may or may not have an active or active MRI, or then who have relapsing remitting MS, which does not show an active MRI, but active, or a progressive MS, which is not active, or with or without progression, or active with or without progression. But these are just newer sort of ideas that are trying to come into the description between, you know, how to maybe be more specific or give more specific subtypes of MS. A name that you come across a lot in the descriptions is that of Professor Ian MacDonald, who I worked with back in the day in London, who has passed away in 2006. He was a neurologist who called together a group of neurologists in 1990 to get together to discuss the current status of how we diagnosed MS, including using MRI scans and other biological tests. And since then, there have been a number of versions of those tests which have come out, and they are often referred to in the clinics about the MacDonald criteria, and that's often used by the neurologists to help with the diagnostic categories. Moving on then, these are just MRI scans, and this is just an MRI, and these arrows are pointing out areas of inflammation within the brain, sorry, slipping there, around the ventricle and just under the cortex. In this particular scan, we look at the brain in terms of 4 different areas, so subcortical, periventricular, posterior fossa, or the lower part of the brain, and then the spinal cord. And then we look and see if there are abnormalities in all of those areas. And in this occasion, there are actually abnormalities in 4 out of the 4 areas. Some people are in the criteria, people talk about having abnormalities in 2 out of the 4 areas in order to meet this criteria for having MS. But in this case, people who have 4 abnormalities in 4 out of the 4. This is just to show that MS is the dynamic process. This is an old time-lapse video where they did serial MRI scans every month for 12 months in a person with MS. And it shows how the MS lesions can come and go. So they can flare up and then fade back into the background. So it is a dynamic process where lesions can flare up and then disappear again. This is just showing the lumbar puncture, which shows here the oligoclonal bands in the person with MS compared to the control subject. And the reason I put this up is that the lumbar puncture is still part of the usual assessment of somebody with MS. And despite the progress with MRIs and so on, we still have the need to do lumbar punctures in order to try to get as much information as possible to help us make our diagnosis as firm as possible. Another interesting area, then, as I've mentioned, is these biomarkers. This is just an OCT device, or optical coherence tomography. These devices are now available in opticians, and you can get them done as part of your eye assessment. And what they do is they look at the thickness of the retina, and they can be great ways of looking at how the retina is performing and how the nerve layer of the retina is performing. We know that that can be specifically affected MS, and you can perhaps measure that over time as another way of looking at the impact of MS. In terms of the principles of treatment, you have the treatment of the underlying disease. So that's something that's trying to keep MS itself at bay and prevent progression. And then you have treatment of the symptoms of the disease, which is more in the moment, trying to make the best quality of life that that person can have day to day, and trying to alleviate those symptoms. And this is just a list of the currently available anti-MS drugs, and just also mentioning the possibility of stem cell transplant, which is another option that is increasingly emerging for people with MS. So that's the current state of play. There are some newer drugs in development and on the verge of coming out, but I haven't put them up there. Now, moving on then specifically to our topic tonight, which is the issue for men with MS. We know that there's about, in the US, there's about 1 million adults living with MS. In Ireland, it's estimated to be 9 or 10,000. And we know that overall, the female to male ratio is 2 to 3 to 1. So roughly that would mean that it's maybe 300,000 or 400,000 men with MS living with MS in the US, and perhaps a similar ratio to our population. In terms of the different types of MS, if you look at relapse remit secondary progressive MS, which is the most common sort of scenario to be in, the female to male ratio is about 2.5 to 1. There is some debate about whether, if you compare men with women at the time of onset of their diagnosis, as to whether men are quicker to progress to getting more progressive MS or secondary progressive MS. If you look at primary progressive MS, the ratio is a little bit less different. So female to male ratio is 1.2 to 1. Again, in comparative terms, perhaps women less likely to have primary progressive MS than relapsed remitting MS in terms of the overall numbers. The other thing then is, are men more likely to progress with weakness or loss of power as their first symptom or their initial symptoms? And there is some data that suggests that perhaps if you compare MRI scans over time and using different measures within MRI, which are beyond the scope of this talk, that there might be different patterns or different effects of MS within the brain for men compared to women. And that brings in the question of the role of gender, female versus male hormones and so on. But this is all sort of early data and the subject of ongoing research. In terms of treatment differences, all of the drugs for relapsed remitting MS are licensed for both men and women. And then similarly with ocrelizumab and siponimod. So there isn't necessarily any gender difference in the meds. There have been some queries about whether if you do sub-analysis of the clinical trials as to whether when men are compared to women within the trials and accounting for all the other factors, that some of the drugs might have a variable impact for women versus men. But again, that has not led to any sort of difference in prescribing practice. But there is one question, all right, which is that if men are more likely in any scenario or on average to have symptoms that affect mobility and so on in a quicker way than women, then should you go for more highly effective treatment for men from the get-go, rather than starting off with some less effective treatment or some drug that is not as strong initially, and then seeing how the person gets on, but maybe going more directly for aggressive therapy. So that's one of the questions that comes up. But again, as we say, these are some overall suggestions. These may not reflect the individual experience of one individual female or one individual male who has MS, which vary across the range. In terms of particular symptoms, then we've mentioned already, could a person with MS have more problem with weakness and perhaps this problem of hypertonia called spasticity? Could somebody with MS, a man with MS, have more imbalance and ataxia? And then, of course, there is the issue of sexual dysfunction, which occurs in both men and women in different aspects and different ways. Some commonality, but also some other issues in terms of erectile dysfunction. So again, those might be some differences. But again, I don't want to necessarily stress and say that men are the only people who have sexual dysfunction, which is completely untrue, because women experience it as well. In terms of conception, again, for women who are carrying a baby, they are going to be concerned about being on medication during pregnancy, and so therefore they will have to discuss individually with their neurologist what meds could be perhaps considered to be taken during pregnancy, what meds should be stopped, how to plan a pregnancy as safely as possible, etc. So that probably goes across all of the meds to a more or less extent. For men, there are two drugs at the moment that might be particularly relevant. So one is the drug called Mavenclad or cladribine. That drug works by affecting DNA synthesis, and as a result could potentially have an effect on sperm function. And therefore, it's recommended that men who are on Mavenclad, who are thinking of having a child, should try to avoid trying to conceive for 6 months post-treatment. The other drug that can have some levels within semen is teriflunomide or Aubagio. And again, conception is not recommended for trying to conceive, is not necessarily recommended for men on teriflunomide. Now, there has been a study, I think, of 16 pregnancies and of women whose partners were on teriflunomide, and I'm not sure that there was any major problem for them, but still, there is a kind of a question mark there and a flag over that. So just something, again, to discuss with your individual neurologist about those specific meds in terms of what impact that might have on your sexual relationships. In terms of spasticity, this is the increase in muscle tone that occurs in the limbs, and it's caused because the brain and spinal cord are having dysfunction due to inflammation of the MS. There are a range of treatments available for that. Drugs called baclofen, which is sometimes called Lioresal, tizanidine or Zanaflex, diazepam, gabapentin or Neurontin, botulinum toxin type A injections, and then a drug called nabiximols, which is sold under the trade name Sativex, which is a cannabinoid spray. All of these treatments are available in Ireland at the moment, except the nabiximols or Sativex. That's not commercially available in Ireland. It has been approved by the Health Products Regulation Authority, so it's okay to prescribe, but it's not actually commercially available in terms of being possible to get funded by the HSE. There have been some companies that are importing it privately, but individuals who use nabiximols under that line will have to pay, and it's reasonably expensive. And that can be used to help treat muscle spasm. There's also another treatment called intrathecal baclofen, which I've mentioned ITB up here. And as you can see, the note about the baclofen is that there is a pump device that can be inserted under the skin and then brought up near the spine, and that can help to deliver the baclofen into an area near the spine and might minimize any side effects that the person experiences generally and might be more efficacious for reducing muscle spasm. Another big area that people experience are lower urinary tract symptoms, or LUTS. So these are, symptoms that there's a whole variety of these type of symptoms, and they are not just isolated to people with MS. They can occur in people with other neurological conditions and also in people with prostatic hypertrophy or prostatic cancer. But they would include things like hesitancy, poor and intermittent stream, straining, prolonged micturition, which is prolonged urination, feeling of incomplete bladder emptying, dribbling. And it can also include storage problems like frequency, urgency, urgent continence, and having to go to the loo at night or nocturia. So these are very, very common symptoms. And in a study, in studies that was done of up to 90% of patients will have those symptoms after 10 years. And it might be one of the first symptoms that people experience in 2 to 10%. It has a significant impact on quality of life. In one study, which was from 2015, of 680 patients with MS, they looked at how people were trying to manage the symptoms. So people were doing things like reducing fluid intake, trying pelvic exercises, oral anticholinergic medications, avoiding certain foods and alcohol. And there were other treatments that were being used then, like botulinum toxin type A, which can be injected into the bladder, electrical stimulation devices, intermittent clean catheterization, intravenous catheters, and collagen injections. So again, a variety of treatments. I think, again, our experience would be that most people would be perhaps in the first section here, but some can get access to other treatment modalities, again, on discussion with your neurologist and on discussion with the urologist and the urology nurse. Sexual dysfunction, again, we've already mentioned, a very common problem and sometimes an issue that's difficult to discuss or talk about. There are a number of things. One is one consider other problem causes, like, for example, before mentioned prostate disease. One can check hormone levels in people, just if they're having difficulty with libido or with desire. As I've already mentioned, we may have people on other medications like antidepressants or tricyclics for like amitriptyline for depression or pain, or amantadine for fatigue, or baclofen for the spasticity, and these drugs can have a negative impact on sexual function. So again, the classic problem that one can be on a cocktail of medication and you could be robbing Peter to pay Paul. Other issues that can be helpful can be psychological support and discussion of psychological issues and factors that the person might be going through. And then in terms of the meds, obviously most people are aware of drugs like Viagra or Cialis, and these are what are called phosphodiesterase 5 inhibitors, and they can have side effects like headache, flushing, nasal congestion, and rarely tainting of vision. And they should not be taken by anyone who's taking nitrates for angina. So anyone who's taking glycerol trinitrate spray, an older person who might be taking those for angina. And there are other interventions as well, like prostaglandins and vacuum devices. Again, usually we would deal with those with the help of the urologist and the urology nurse. Another issue that can come up for men would be around genetics and genetic risk. And certainly there is an increased risk of MS in relatives, in first-degree relatives. So the overall risk is about a 3% chance that if a person has MS, that there'll be somebody else in the family with it. That's about a 4% risk for siblings, a 2% for parents. So that's obviously the person might know already about that, and about a 2% for risk for children. Or the other way of putting that is that there's a threefold greater than age-adjusted risk for second-degree and third-degree relatives, and a 10 to 30-fold degree risk for greater than the general population, which is generally around 0.1 to 0.3%, depending on the study. So undoubtedly, the risk is definitely increased compared to the general population, but still, if you look at it another way, 97% of people probably won't have any other family member affected. Mood issues that are there, we know that certainly things like depression are more common in the general population, and the symptoms can include irritability, discouragement, problems with memory, concentration, fatigue, insomnia, poor appetite. Guilt and poor self-esteem seem to be perhaps rarer than in depression due to other causes or linked to other issues in people's lives. It can occur throughout the course of MS, even in mild forms of the disease, and it can occur perhaps relatively commonly in the first few years after diagnosis is made. And the most common kind of correlation with it is having more MS symptoms, and that does seem to correlate with depression levels and anxiety levels. Another area that comes up then is around physical activity and exercise in MS. It has to be pointed out that physical activity and exercise are not necessarily the same as rehabilitation. So that's an important thing to say. So rehabilitation is where you're getting interdisciplinary help from other people like physiotherapists, and that's trying to maintain optimal physical function, promote functional independence, prevent complications, and improve quality of life. So that's slightly different to activity, but physical activity is any body movement which results in a substantial increase in energy expenditure over resting levels. Lifestyle physical activity is the daily accumulation of at least 30 minutes of exercise, including all planned or unplanned leisure, occupation, or household activities that are at least moderate to vigorous in their intensity. And then exercise is a form of leisure time physical activity that is usually performed repeatedly over an extended period of time with a specific external objective to improve fitness, physical performance, or health. There are interesting scales that are used. One is called the Borg Scale, which rates activity from none. So that would be like reading a book or watching TV, to something like very, very hard, like a finishing kick in a race or another burst of activity that you can't maintain for long. And so that's a Borg scale that's usually used to help. And then this is just another scale of rating of perceived exertion from nothing at all to very, very hard maximal activity. There was a paper in the MS Journal, including with input from Dr. Susan Coote, who's an academic physiotherapist in the University of Limerick that many people will know. And they tried to come across recommendations for physical activity across the range of people's lives with MS. And I don't want to go into the micro detail. The document was actually very specific and very helpful. But they say that healthcare providers should endorse and promote the benefits and safety of exercise and lifestyle activity. Early evaluation by a physical or occupational therapist or exercise support scientist experienced in MS is recommended to establish an individualized exercise and lifestyle physical activity plan, taking into account comorbidities, which means other illnesses the person has, and the fluctuation of symptoms. Healthcare providers should encourage greater than 150 minutes a week of exercise, or a great 150 minutes weeks of lifestyle physical activity. Progress towards these targets should be gradual based on the person's abilities, preferences, and safety. If disability increases and exercise physical activity becomes more challenging, referrals to specialists are essential to ensure safe and appropriate prescriptions of exercise. And when physical mobility is very limited, exercise should be facilitated by a trained assistant. There are some areas that were recognized that could be barriers. So things like, you know, where you live, the social environment, the health conditions like fatigue, cognitive and behavioral issues, the cost of things like gym membership and time that you could give. And then on the other side, facilitators might be physical environment, social environment, health condition, so things like accessibility and disability-friendly venues, role models, peer support, appropriate goal for disability, rest for fatigue, helpful cognitive things like accomplishment and self-management, cost programs, grants, and equipment from the MS Society, which we know does exist, and improve time management and prioritization of exercise within that area. So they're just some thoughts and some areas, and I thought then that I might just end my talk now and then just return to Aidan and ask if there are any queries or issues that people might wish to bring up.
Brian, thanks very much for that very informative talk. There hasn't been a lot of activity in the chat in terms of questions. There's one particular question that has come in, and it's in relation to baclofen. And the question is baclofen the same as baclopar?
Yes, generally there would be generic. I mean, obviously I can't always say how the generic name would go, but generally the generic, if it sounds like it, it probably is, but always check because there are similar sounding drugs out there that can sound the same. But baclopar would be baclofen. Yeah, that's generic. It's a generic form. The classic name of the drug over the years was called Lioresal, which was the name of the company that made the drug originally. But baclopar would be another generic version.
And another question here, Brian, is do any of the medications warrant earlier or more frequent screening for the likes of PSA bloods?
Not necessarily. One question that comes up with drugs that suppress the immune system would be whether your immune system has a role within your body to protect you from outside invaders like virus and bacteria, but also maybe has the role to defend you against abnormal tumor cells and abnormal cancer cells. And it might, maybe if there's a way of recognizing when cells are growing out of control, that the immune system might destroy them before they take hold. So one of the theories that comes up with immunosuppression is that by your immune system being suppressed, maybe those defenses are down a little bit. So, you know, there have been some studies suggesting that, for example, that with some of the drugs that cancers might be slightly more common in people on the drug versus the placebo. But in general, we would just keep a good weather eye, keep monitoring skin and so on. And then obviously if the person noticed any change in their urinary symptoms, then they might get a PSA test, and depending on what age they are, and also the debate around whether the PSA is a good screening test once you hit a certain age as well. So I think it's no harm to remember it, and if you did notice any change in your urinary symptoms over a relatively short space of time, it might be worth getting a PSA check with your GP and just keeping in mind that you might be on other meds that are there. Great.
And another question here, is there any issue with the use of both MS medications and Viagra together?
No, generally, one can make a distinction between the long-term strategy of trying to prevent MS getting worse, which is what drugs like cladribine or tisabri or beta interferon, that's what they're trying to do. And they work over time, and they hope to have you in a better place in 3, 4, 5 years down the line. And then the symptom-based treatments then are quite distinct, and they shouldn't interfere with the Viagra. The virus should not have an effect on the anti-MS drugs, the long-term treatments. Having said that, again, as I've said, you can end up on a cocktail of drugs for different reasons, for different symptoms. And it's always worth just checking with your pharmacist to make sure that there's no interactions or no, that people didn't consider when the drug was being prescribed. So I think it's always worth checking to make sure that there are no interactions or anything like that that would be there, and discuss it with your healthcare provider then.
Okay, excellent. And one more question here, Brian. Can you please talk a little bit more about stem cell treatment? So I suppose maybe what stage stem cell treatment is at? Is it available in Ireland, or are there good official referral pathways?
Okay, so just to go through that again, we, as we've already mentioned, we consider that MS is an autoimmune disease. We still don't have the exact reason why it triggers in a particular person at a particular time. That work goes on about. We've discussed about genetics and environment and how those two interact and what factors might be there. But anyway, the immune system is involved, and our immune system is derived from our bone marrow. So the white blood cells and the lymphocytes come from the bone marrow. And for whatever reason, these cells have developed in people with MS, and they continue to exist within the bone marrow, and they continue to be produced even with the meds. So the idea of bone marrow transplant is that by, if you like, you want to get rid of those cells that are triggered against MS or triggering for MS. And so what they do is they give you a drug to stimulate your bone marrow to produce bone marrow stem cells, and they are harvested from the person. So the cells are taken from the person themselves at an early stage in development. They're put to one side. You then give chemotherapy to the person to ablate the old bone marrow to basically destroy their old bone marrow. And then you take those early primitive bone marrow cells that you've harvested and transplant back in, and then you hope that they will take on and they will repopulate the bone marrow. And because they grow very quickly, they grow like wildfire, they then can go into the bone marrow and retake over and produce the red blood cells and the white blood cells and the platelets that you need. And the idea then is that you've wiped the immune memory. Now you've wiped it totally, so the person might have to be vaccinated against all the things they were immune to before they had the transplant. So things like measles and German measles and things like that, that might all have to be done again. But hopefully in the act of doing this, you've destroyed the cells that cause MS. And unfortunately, that blunderbuss approach has to be taken. You have to knock out everything because we can't identify those cells distinct from all the other cells in the bone marrow. So you have to knock out the whole thing to get rid of them. So it's a bit of a blunderbuss approach. At the moment, people have to go have had to go abroad for that to be done, usually to the UK, and we have a liaison with the UK and a kind of a good relationship with them for treatment. Some people have also gone abroad themselves with their own money and gone to centres where they paid themselves for treatment, maybe to more distant places like Moscow or Italy or other countries. And obviously the big thing there is to make sure that your aftercare when you come back is all set up and programmed. And I suppose the worry you would have with that would be if you went away somewhere quite far away and you got sick while you're out there with this transplant, because it can make you very ill. You can be very ill during it. It could be quite serious for you and your family. In terms of Ireland, I'm part of a group that is setting up bone marrow transplants for Ireland. So we have some hematologists who do the transplant and neurologists, and we're meeting on a regular basis, and we hope to be going forward with that within the next 6 to 12 months so that people will not have to go abroad. As you probably know, bone marrow transplants take place in Galway and in James in Dublin at the moment anyway. It's not that we can't do them. They are done for things like leukemia and lymphoma in Ireland, but they just haven't been done for MS up to now. So we hope to get that up and running. In terms of, just to make the point as well, that this is to do with the immune system and basically knocking out the cells that cause MS from the immune system. It is not a stem cell transplant for the nervous system. So the other side of that people talk about with stem cells would be, could we regenerate the nervous system? Could we restore it and repair it? And again, that's what I alluded to at the start. And that's quite a complicated thing because unlike blood cells, neurological cells or neurons do not turn over very quickly. They grow slowly. They're very specialized. They have a great specialization to control the nervous system, but in that specialization, they become a lot more vulnerable and a lot more hard to repair. So, and that work goes on. So that work goes on, and that's another side of things, which is not. There's no commercially available stem cell transplanting of any bona fide kind at the moment. People can go and get stem cells, which is, but some of that stuff is bogus, and you want to be careful and check it out.
It's good to be, well, it's optimistic firstly, and secondly it's good also to clarify the difference between the blood cells and the nervous system cells. One more question in terms of treating benign MS. So is benign MS usually treated, or is it usually just left alone?
That's a good question. So, you know, if you look at the initial time when somebody's diagnosed with having MS, you know, that's obviously a very emotional time and very stressful, and you know, takes a lot to get used to. But sometimes the symptoms themselves can get better, you know. So if you get optic neuritis and it settles down quickly, the person can actually feel quite well after a couple of months, and the symptoms fade, and they may actually feel very well back again. And depending on their frame of mind or their thought process, and depending on their discussion with their neurologist, if the dust has settled a little bit and they get their head around it, and if they're maybe a little bit skeptical or wary about meds, maybe wondering about the side effects, and, you know, just not wanting to medicalize their lives too much, and if things are going pretty well, they might decide not to do anything. And I have definitely got a good bunch of people who follow up with me, who I've been following for years, over 20 years at this stage, who remain remarkably well. And who have not accumulated any major disability, and they've never been on treatment. So yeah, it can happen. Roughly, if you look at people who are not on medication, and you might say, well, if you're not on medication, that must imply that you must be feeling pretty well, or that you're doing okay, or, you know, that you're not worried by your symptoms. It's probably about 20% you know, around. That's what we would say, that not everyone with MS will consider long-term treatment, and we would say maybe 20% of people aren't on long-term treatment, at least, and so that might imply that they're doing well. So yes, it is possible to remain well and not to consider treatment. And and if you do pretty well in the first 2 years, so if you get your symptoms and you stay pretty well and don't get any major relapses in the first 2 years, and your initial symptoms recover very well, and you're left with very little or no disability, then in my experience, people in that scenario can do quite well without us intervening. But on average, most neurologists, I suppose the problem is that you can't always predict that initially. Yeah. You know, and therefore, I think most neurologists would have the edge to recommend treatment. But you know, as a general principle, but there are definitely some people who can stay quite well without intervention. Okay, and Brian, the last question we have here, it's in relation to a bladder treatment issue. It's a drug, I think, called Betamega. And yes, just is it specifically for bladder issues? Yeah, that definitely would be a drug that would be used for bladder problems, and so it would be helpful. And there's a whole range of these things like detrusitral, tolterodine, that can be used. They're kind of, and what they try to do is make the bladder more relaxed so that you don't have the urge to go all the time, and it sort of prevents that. Another treatment is where you give Botox injections into the lining of the bladder, and that can stop it contracting too much, and that can be helpful. And then another tablet that we sometimes use is a drug called desmopressin. And what that does is it inhibits urine being formed. So what it does is it makes the kidney turn out less urine, and so less is flowing into the bladder, and therefore you get less urge to go. The problem with that drug is it can only be used once a day, because if you use too much of it, you can get too much water in your body, and that can cause serious health problems. So that's it, and it's not recommended for anyone over 65. But that's a thing called desmopressin or desmo spray, or that's another one out there. And then one of the problems, the other problem with the bladder is that it can be contracting too much. Sometimes it's not contracting enough, where it gets too relaxed and it doesn't have enough strength, and it kind of fills up, and it doesn't. And that's much more difficult to treat with medication. And that's where the intermittent catheterization or catheterization can come in with that side of things. And the final question, it's really in relation to the availability of neuropsychological assessments and services. And would it be routine for neurology teams to refer people in for neurological psychological assessments? Yes, so basically it's probably something that hasn't been done terribly well up to now, partly because of resource issues. There are, to do a proper neuropsych assessment probably takes about 2 hours, and you sit down with a neuropsychologist and they have a variety of tests. So there are people are trying to bring in sort of cognitive tests that could be done in the clinic, maybe briefly. And some people attending certain clinics will be already maybe having those. And in some centres in places like Germany, they do a very careful psychological assessment at the start, and then they follow you up regularly, so to measure the outcome. And we know that cognitive problems are a serious issue for people with MS. So I think it's a growing area. It does add time to be done properly, and sometimes that time hasn't been there. For instance, in CUH, we don't actually have a neuropsychologist on staff in our department, which is a huge loss. So we're trying to work on that and grind it out slowly. It's always sometimes pushing us thrown up a hill. But psychological assessment certainly it is helpful. And if you want to discuss it with your healthcare provider, with your neurologist, even if they can't get it for you kind of as a standard where you get it every time you come to the clinic, it should be possible to do an assessment, and also for them to refer you to a neuropsychologist that would be hopefully attached to the larger centres.
Great. Brian, I'd just like to take this opportunity just to thank you very much. And I think that one of the take-home messages from this evening's talk really is around keeping the door open, asking questions, and I suppose journeying with the neurologist. So with issues, whether it's around continence, sexual function, or even worries about progression into the future, it's about keeping that conversation going so that good health plans can be made. Yeah,
I see one other question there, which is just around I think there's one other question, which is just on the Vampira. So again, from someone I know well from TIP, how's it going? So Vampira is a drug that what it's supposed to do is to have an effect on nerve transmission. So what happens when the myelin is affected in the nerves is that the conduction of nerve impulses is delayed and slowed down. And what happens, and that then leads to more symptoms. So supposedly what Vampira tries to do is to speed up that process of nerve transmission to make the nerve more efficient and to conduct the nerve impulse faster. And in so doing, then that might help to reverse some of the symptoms. Now, in a study that was done in the States a few years ago, they showed that of 100 people in the study, 40 of them reported a greater than 25% increase in walking speed with Vampira. So not the majority, but about 40% of people reported increased walking speed. And on that basis, the drug was given a license. So there is some evidence that it does give help the efficiency of walking and may improve walking speed. And that's why when people get it, sometimes they get a baseline assessment of walking speed and then get it done again a month after it started. Some people have said, like a lot of things, there's a degree of subjectivity with these things. It's not always very objective. And some people swear by it and say that they think it's, in terms of subjectively feeling better on it, if you like, or saying that I think there's a benefit, and have said, oh yeah, I really feel it makes a huge difference. Others have said, yeah, I'm not so certain. Again, it's certainly there to try, and it's available. There is one issue, all right, in that it's not recommended for people who have relatively poor kidney function. So you have to have good kidney function to get the drug out of your body. And so that has to be tested before you can go on the drug, and you have to meet certain criteria for that to get it. But it can be worth trying. But then, you can also add in things like the spasticity, the high muscle tone, and how that interferes with walking. And, will Vampira really offset that? So it's there, and, it's a mixed bag. Some people would say it's great, others would say it made no difference, but it should be available. But it is commercially available, and it's available because there was some trial evidence that suggested that it was useful.
Great. So Brian, on that note, I think maybe it's just an opportunity just to thank you very much for your time and your expertise this evening, and just to let the people that are listening in know that this session has been recorded and it will be available on the MS Ireland website in the coming weeks. Yeah, just I think there was one other question about lumbar puncture. Just to say that, sorry, and I keep interfering, Aidan, and I'm cutting out cross. No, you're okay. We'll end it up, but just for that person, just in case. So basically, lumbar puncture involves, there's a membrane that surrounds the brain and goes down to the lower end of the spinal cord called the dura. It's called that because it's hard. It's a durable membrane, and within that, the spinal fluid is there, and that circulates around the brain and then goes right down to the lower end of your back. Now, as everyone knows, we generally don't biopsy the brain because you have to go through the skull, and the brain itself is so delicate. So getting the lumbar puncture is one way of us getting closer to the nervous system and getting that fluid, because it bathes the brain, and analyzing that fluid can help us. And we know there's a particular abnormality that comes up in about 90 to 95% of people with MS. And as I said already, it is part of the criteria for diagnosing it. However, the problem with puncturing that system is that when you puncture that system, it has a certain innate pressure. And when you put in the needle and take out the needle, that pressure is lowered. And so some people then can get this awful headache afterwards called a post-lumbar puncture headache.
and it usually, that's because there's a slight leak of the fluid through the hole where the lumbar puncture was taken, and that then is what causes it. Now that usually sees itself off, and in the majority of people do get better, but some people do report ongoing problems for a longer period after the lumbar puncture, and a lot of people, if they've had a lumbar puncture, they wouldn't be that keen to have it again. But I don't know if it would have an effect on your joints, particularly, to be honest. I'm not sure about that.
Great.
Okay.
Okay, I think that's the edge of the questions. They keep on popping in just as I keep on saying cheerio.
Okay.
But Brian, listen, thanks again. And as I was saying, it will be up on the website in the next week or two for people to check in. And if people have any questions in relation to the issues raised, they can contact us at the MS Society, and we'd be more than happy to take their questions or refer them on to other agencies as appropriate.
Okay, take it easy, everyone. Have a good evening.
Thanks very much.
Okay,
Cheers.
see you later. Take it easy. Bye.